India is the diabetes capital of the world. We are home to over 100 million people living with diabetes. Now, a test which is used to measure diabetes, called the glycated hemoglobin or HbA1c test, may not be the correct measure to measure diabetes. So, this is one of the findings that countries' top diabetologists have come down to, and they published this in a paper in Lancet recently. So the doctors have said that blood glucose levels should also be assessed in like multiple other ways, such as using the oral glucose tolerance test or OGTT, also self monitoring or continuous glucose monitoring or CGM. We have Dr. Anoop Misra, who is the corresponding author of the study, with us today. We'll try and understand from him how this may not be the correct measure of diabetes, what this test is about, and a little more on how did they arrive on these findings, and what this really means for the large-scale diabetes screening program in a country such as India. Dr. Anoop is the chairman of Fortis CDOC Center of Excellence for Diabetes, Metabolic Diseases, and Endocrinology. Welcome, Dr. Anoop. Thank you for joining us. So for years, we know that HbA1c test has been used and has been considered a gold standard to measure, to diagnose diabetes. So your study essentially says that this test may not be the appropriate measure. So what does this really mean? First of all, for people who don't understand, what is this test? And what does it really measure?
We wrote this paper. This is pending for a long time, actually. Every day, when a patient comes to us, we see the reports of blood sugar. We see reports of glycosylated hemoglobin, which was called earlier and glycated now, and make a judgment. Number one, whether the patient is diabetic or not, and number two, whether the patient is well controlled on, if already diabetic, then whether the patient is well controlled on drugs, etc. So let me just go back and what hemoglobin A1c is. This is one test which indicates average blood sugar level over last 3 months. Why is it preferred in general? Is because it does not require any fasting. And it does not vary with the time of the day, and hence can be taken at any point of time. Initially, when it was discovered in 1970s, the use was primarily directed towards monitoring of diabetes. And one of the major trials, diabetes complication control trial in type 1 diabetes, proved that hemoglobin A1c actually is highly correlated to the complications of diabetes. So increasing the hemoglobin A1c, there is increased risk of complication. And that was one of the first trials where everybody started using hemoglobin A1c for monitoring of diabetes. In 2010, people thought, why not use it for diagnosis of diabetes? Because some people cannot fast for a long time and they cannot do multiple glucose monitoring and so on. So WHO and other agencies listed it as one of the key components for diagnosis of diabetes also. But the blood glucose testing continued as a gold standard for diagnosis of diabetes and one of the key standards for monitoring of diabetes. Now, why are we talking about the problems in interpretation of hemoglobin A1c now? Is because we have seen enough people who have discordance between the two tests. For example, let's say somebody's hemoglobin A1c is slightly high, 6.4, it's not very high, and the blood glucose levels are entirely normal. So what do we label as? Is he diabetic or is he not diabetic? Or is he pre-diabetic or is he not pre-diabetic? So we cannot be sure. One of the tests is not showing correct. Similarly, if we see a patient who has been coming to us on multiple drugs, already proved patient with diabetes, and his blood sugar monitoring is showing high. So fasting is 200, PP is 250, all these are high values. And hemoglobin A1c is showing less than 7%, which is acceptable level of control. So what do we believe? Do we believe blood sugar or hemoglobin A1c? So this has been plaguing our mind for quite some time. And then we started digging on the background of it. Uh, we already had some idea, but more literature research was done. And here we are with this particular article, which should have been written some time back, but we have written it now anyway. And this has been discussed widely now amongst doctors, researchers, clinicians, and the media.
So, Dr. Anoop, I also want to understand how actually did you arrive at these findings, and because essentially you are saying that the test is inaccurate or may give incomplete outcomes. So, does this mean that the public health surveys that are based only on this test are sort of misrepresenting India's true burden of diabetes?
Yeah. So it's like this. I won't say that this is entirely inaccurate. I would say that in many people it is not correct. Uh, who are those people? Who are those people where it is not? It is likely to be not correct. Those people who have anemia. So somebody, especially women, in our country, lots of women have anemia, and in them, hemoglobin A1c may be not showing the correct value. Uh, Anemia is due to many factors in our country, and in women, it is due to iron deficiency anemia. But there are other problems. For example, there are problems like the hemoglobinopathies, where hemoglobin is not correctly formed because of genetic problems. Uh, and some of these are, say, for example, sickle cell anemia, beta thalassemia. We do see these patients every day. Uh, and also an enzyme defect called G6PD deficiency. Now, you would want to know that how many people suffer from such disorders, and in how many people we should be, sort of more vigilant about the hemoglobin A1c, likely that it may be incorrect. So let me give you an idea. Approximately 50% in general, in general, people in this country, in India specifically, have some sort of anemia. And the some people have lesser likelihood. For example, you and I sitting in Delhi may not have that much of anemia, but the farther you get from Delhi to the rural areas, there is a wide prevalence of anemia. And some people in some tribal areas and some other castes, etc., have hemoglobinopathies. That is genetic problem, and enzymopathies for some unknown reason. So, in I would say in around ranging from 20% to 50% of the people, there is a good likelihood the hemoglobin A1c does not reflect the correct burden of blood sugar. And in such cases, we have to be cautious.
All right. Can we also know from you how widely this, I mean, how wide this mismatch can be between the results of the HbA1c test and other measures? So, diabetes is measured by other tests also, like oral glucose tolerance test and CGM as well. So, how wide this mismatch is likely to be?
Okay, before that, let me tell you something more. Uh, Mismatch may occur due to anemia and hemoglobinopathy, but mismatch may occur otherwise also. For example, let me give you just example from a paper from 1980s, 1990s, earlier research paper. So let's take one value of hemoglobin A1c, 8%, uncontrolled diabetes, 8%. It's above 7% is uncontrolled diabetes. Now, the research study looked at what would be the blood sugar at this 8% hemoglobin A1c. And they found that the blood sugar varies from 155 to 218. Now, 155 is not too bad, 218 is bad. So, this is the range that the 8% hemoglobin A1c is covering. Now, 155 averaging at what A1c? That would be 7% A1c. And 218 averaging at what A1c? 9% A1c. But it is being reflected within that 8% A1c for some reason. Now, this is the study from the West. This is the study not done in India. So variations are there in hemoglobin A1c. Otherwise also, variations are there due to anemia. Variations are there due to old age. Variations are there due to obesity. The variations are there due to kidney dysfunction. Variations are there due to season changes. Variations are there in people with liver problem. Variations are there people who receive blood transfusion, or variations are there in people who have the advanced organ dysfunction. So you can see how many people can have variations in such. Especially, let me just give you an example of kidney disease, where multiple factors actually affect hemoglobin A1c. Anemia is widely prevalent. Blood transfusions is also prevalent. So, multiple factors may affect a person where hemoglobin A1c interpretation may be problematic. In such situation, given all this, in Indian population, and we have written this paper only on Indian population. I'm not talking about US population. I'm not talking about European population. This is Indian population because we are beset with all these problems. Not US. US doesn't have that much of anemia. So, in Indian problem, if you are doing a survey of population for diabetes, please do not go by hemoglobin A1c. Go by the blood sugar, fasting blood sugar, and give a 75-gram glucose to the person and 2 hours blood sugar. That is the gold standard for diagnosis of pre-diabetes or diabetes in our population. And this has been considered by ICMR, most of the people who are doing surveys. So we will not accept the surveys which depend only on hemoglobin A1c.
So you are essentially saying that combining it with other tests is the correct way to go ahead in measuring.
Combining with a simple test like blood sugar. For example, let's say two components. One, diagnosis, other, known diagnosis, the monitoring needs to be done, and we should adjust the medicines accordingly. So, diagnosis, oral glucose tolerance test, which I already told you. 3 days of normal meals at home, 4 day, after 8 to 10 hours of fasting, do a blood glucose and give 75-gram glucose in one glass of water to drink over 5 minutes and take a blood sugar after 2 hours. Simple, not expensive. That gives the idea of whether the person is normal, pre-diabetes, or diabetes. I always do such tests, and some people who come with A1c, oh, I have become diabetic, please treat me. I said, I will not treat you because I don't know your diagnosis. I will do oral glucose tolerance test and then only treat you if required. And you will not believe me. 50% of people where hemoglobin A1c is not very high and they come with such report 6.4, 6.5, 6.6, 6.7 also. they prove to be non-diabetic. And going by A1C, they would have received the treatment. Now, coming to the monitoring of blood sugar, monitoring of diabetes. Monitoring of blood sugar still remains one of the best ways to know whether your treatment is effective or not. And I tell my patients, if you monitor one or two sugars in a week, 10 days time. So, for example, one fasting, one post breakfast or post lunch or post dinner over 10 days, then do another set of sugars. Likewise, 6 to 8 blood sugars in a month. Not much, not expensive. Get me that chart in 3 months' time. I will see hemoglobin A1c also, but I will see this chart first and evaluate whether these sugars are within limit of control or not. And if both are matching, I'm very happy that A1c says the same thing as the blood sugar. So we are not actually putting A1c away. We are taking it together with blood glucose, but I'm giving primacy to the blood glucose and taking A1c as a secondary measure. I'm not taking A1c as a primary measure. Now, unfortunately, what happens is that I know about these things, many physicians know about these things, but many of my colleagues who are in various other areas, cardiology and so on, they will rely exclusively on this because they have been taught like this. So it's not their fault. But India specific problems we have to solve, we have to see. And this is the India specific problem. So I often they say, oh, A1c is more than 7. Please, Dr. Misra, please have a look at this patient. I say, all the blood sugars are well under control. I will disregard A1c in this patient. In some people, no anemia exists. Nothing else exists with what I've told you. Still, A1c is discrepant. Then I write on the top of the file, the A1c is discrepant. Please take only blood sugar in monitoring in account. So this is the reality as far as India is concerned. But let me tell you, this is not something which is very specific to India. This is specific to even surrounding countries. And one of the major studies come from Malaysia also, where similar findings have been researched and published. So in countries where nutritionally compromised population is there, this problem will be there. Now, when this was published, I put it on Twitter and I got a response from Africa. And what they say is, nobody talks about Africa. You are talking about India, but similar problem exists in Africa, and nobody is talking about that. I said, that's your country. Please talk about it. I'm sure in Africa also similar problem exists.
So you were just talking about the mismatch, and I asked that question. So I have a follow-up question on that. You said that so the mismatch always existed between the A1c and the glucose monitoring and others. So then why A1c became the gold standard and why people started relying only exclusively on that test?
See, it's simple because Western countries, this is not a major problem. Although it has been talked about by some people, it's not talked about by many people, nor do they see this thing. Their A1c may be a more robust parameter in US, in UK, in these developed countries, but A1c is not a robust parameter in our country. So if we don't talk about our country, we take everything from the West, that's not good. I never believe in that. And we must develop our own data, our own research. We must talk about the things which are prevalent in India. And this is something which is highly prevalent in India, that this mismatch may occur and that this has not been talked about earlier. Now we are making everybody talk about it.
So you are saying because we picked it from the West and they've been using A1c, so we continue to use it as a gold standard, and it became the only sort of reliable test, so-called reliable test for measuring
Okay.
diabetes.
So let me tell you, it's not that people have not researched in India. In this paper, we have, in a table form, we have given all the research studies which have shown mismatch and clearly indicating that anemic parameters must be done to interpret it properly. So people have researched this in this country. What we have done is to collate everything together, but also take taken recent data. Recent data comes from UK. Now UK has sizable Indian population, sizable black population. And their very interesting study, which we have put in this paper, shows that the G6PD deficiency, which is an enzyme problem, occurs in quite many people of black descent and South Asian descent. And it does not produce any symptoms. Like anemia may produce symptoms, but it does not. And in such cases, hemoglobin A1c may be less by 0.9%. So, for example, let's say somebody's A1c should be 7, and somebody else is, uh, you know, the carrying this G6PD gene and has a G6PD deficiency, then A1c is 0.9% down to 6.1. That means what? Delaying the diagnosis, if you are relying on A1c, by approximately 4 years. And that means in 4 years, how many people will develop complications? 37% of the people will develop complications because they are not diagnosed properly. Because you are basing the diagnosis on A1c, and these are both Indian and African people. So this is the new data. Just 1 month back, 1 or 2 months back, it has come out in diabetes care, adding further meat to what we are saying, solidifying our argument. Now, it's very difficult to do a G6PD. It's not easy, not available everywhere, and it is going to be expensive also. So that means there are hidden things like G6PD, which may delay diagnosis, which may increase complication, and you are very, you know, you're very happy that you don't have diabetes, but actually you have diabetes.
I think one of the last questions. So, what do these findings really mean for? Because our country has large-scale diabetic screening program. There are many with diabetes
So
living.
very simple, very simple. That for diagnosis never depend on a hemoglobin A1c. That is my emphatic argument. Always depend on blood glucose by doing oral glucose tolerance test. Number two, for monitoring, take both in consideration, blood glucose values as well as the hemoglobin A1c. And if somebody's hemoglobin is low, get the test done for iron deficiency and so on if you can do, and consider hemoglobin A1c as a suspect. This is very simple. All you have to do is to do hemoglobin to see whether hemoglobin is less. If it's less, suspect hemoglobin A1c. One more thing, let me tell you, hemoglobin A1c is average of 3 months. It does not show any fluctuations. Now your sugar may be fasting may be 120, but post lunch is 250, and post dinner comes back to 140. Average blood sugar 7%. But if you see the fluctuations, then you say, oh, I've got so much of post breakfast sugar, 250. I must control it. Then we use specific drugs to control just that much, 2-3 hours of time. So fluctuations are not shown by hemoglobin A1c. Even diagnosis of pre-diabetes is not completely shown by A1c because pre-diabetes has two components. One is impaired fasting glucose, where fasting blood goes slightly high, and other is impaired glucose tolerance, where post glucose is slightly high. Both have different connotation and different control methodologies. HbA1c will not show. So, in fact, sometimes blood sugar monitoring will also not show the fluctuation. Then we use continuous glucose monitoring systems. So, it is not so simple. It's not that we get we go do A1C and we get information. No, we don't get much of information about the variations. We don't get any information, zero. So let me give you an example. Today, the temperature is 25 degrees. Tomorrow is 30, then 25, then 30, then 20. 3 months later, you say, give me one parameter for your temperature, and I will say 27.5. Is that correct? No, incorrect. So everyday variations also need to be seen. But that's beyond the purview of this article. I'm telling you that other fallacies also. But our article is mostly focused on the anemia and rest of the things. And nobody who's a researcher, scientific mind, can actually contest my article. I'm that much confident on this.
Okay. This also essentially means that the numbers we have of the country, the diabetes burden numbers, are maybe wrongly estimated.
No, but not every study has relied on hemoglobin A1c. The study have relied on oral glucose tolerance test or fasting blood glucose. Only some of the recent studies, and I won't mention where, etc., where we have written letter also against that, relied on A1c, and we criticize that.
I just wanted to draw away your attention to another important development that's going to happen this month. The patent for semaglutide is expiring, and a lot of people have been writing about that. So I just wanted to get some quick comments from you in terms of what this will mean for India as a country with a high diabetes burden. And a lot of people are expressing concerns because generics will flood the market. So regarding quality of generics and how that is going to turn out, what do you have to say on that?
No, I'm very happy that such a thing is occurring, because uh, around 25% of our patients cannot afford current semaglutide or tirzepatide brands. They are so expensive, and they need it, but we can't give it. So if prices come down, we will be able to cover a whole lot of more people who need it. And the other thing is that availability of this semaglutide, because of multiple other companies getting involved, their distribution network is probably going to be much more than the single or one or two companies which are currently marketing this. And so the availability of semaglutide will be far-reaching in India. As far as the generic and the standards are concerned, I'm not the best person to ask this question. I'm sure Drug Control of India would be a better person. There is some always question marks about generics, but there are studies which show that generics are as good. So I won't know where we would stand as far as that is concerned. But most of the companies which are going to make it, they are fairly standard companies and with a good track record. So I expect the good quality medicine from them.
Okay. All right. I think these are the questions I had. Thank you so much, Dr. Anoop, for joining us and for this fruitful discussion. Thanks a lot.
Thank you.